Good morning. Thank you, Marcus, for that kind introduction. It's a pleasure to be here at Vienna for this EAO meeting. I would like to start by thanking to the EAO organization and, of course, to Invibio for their kind invitation for us to be here today and to be able to show you our experience with this new material, the PIC. So for the last 20 years, a little more than 20 years, we have been rehabilitating our edentulous patients with what we call the Malo clinic protocol. This protocol has two different phases. The surgical, that is made using this technique that Dr. Malo developed more than 20 years ago, called the All-on-4, and that today is widespread around the world. And the second phase, the prosthetic phase, in which we develop what we called the Malo Clinic bridge. These bridges are made for be used with All-on-4, although they can be used with 6, 8 implants, and they consist of a CAD-CAM titanium framework that is prepared specifically according to the material that we are going to use for veneering it. Usually, the upper cases are made with ceramic as a veneer material. So we prepared the titanium frameworks in a special way to be used with individual ceramic, all ceramic rounds that are cemented in this framework. And we already published this technique more than 5 years ago, I think. And this has been one of the techniques that we use for the rehabilitation of our patients. We also use other materials for veneering, like acrylic, and then for those cases we prepare the titanium frameworks in a different way. These bars are designed for be used with acrylic stock teeth and pink acrylic for the gingival tissue. And of course we can achieve a very good result according to the acrylic and to the stock teeth that we use and to the harmony of the setup. But this technique, this protocol, has been working very well in most cases. I can show you this case that I did in 2004 using a Malo bridge ceramic, in which we have ceramic individual crowns. At this point was zirconia covered with porcelain, and an acrylic Malo bridge in the lower. So years have passed, and this is how we have these restorations 14 years later. And you can see that some staining, of course, close to the gingiva, and we can see the wear of the acrylic teeth in the lower, but it's a good situation. 14 years after, I think that we should be happy with these cases. Unfortunately, not all the cases comes like this after this time. And in some situations, we can see that the time is much more cruel to our restorations. So in some situations, this is what we observe after some years in function. And you can see that there's a lot of damage to these prostheses. You see that one of the crowns were discemented. You can see fracture in the pink material, and you can even see that 2 lower acrylic teeth were broke in the middle. Another situation, also catastrophic, in which you can see the fractures on the ceramic. And when I see a situation like this, I only can imagine the stress that this material have been put to. The fractures of the ceramic due to the tension that the patients can provoke is huge. And here, on the right side of the picture, you can see that even the titanium framework is broken. And in these situations are those that I think that PEEK material has a huge advantage over this type of situation, because with titanium, there's no shock absorbance. The rigidity of titanium doesn't allow for any forces to be supported by the framework. They are all transmitted. So in these situations, I think that PEEK is really something that can help us protecting our restorations. And so when InVibio approaches, for me it was extremely interesting to have the opportunity to test the material with the resilience of PEEK. And this is the challenge that we propose to evaluate the behavior of full large frameworks and see how they will resist and how they will behave in comparison to the titanium frameworks, much more rigid. For me, it's not a question if it will or it will not work. I think it will work. It's more a question of how is the best way, the best materials, the best techniques to use and to obtain the best capacities of the PEEK material. So we propose to do a study to evaluate this kind of possibility to use PEEK as an infrastructure material. And the first thing that we did was a pilot study. This pilot study was a very small one with only 4 patients and 5 prostheses. So one of the cases was a bimaxillary case. And it took us about 1 year observing what happened to these first frameworks that we produce. And I'm glad that we did these pilot tests, because one of the things that during this period we discovered was that this prosthetic screw was damaging the PEEK framework. I can show you here what we observed on the cylinders. The neck of the cylinder, where the thickness of the PEEK material was smaller, started to become damaged by tightening the screw. And if this would continue, what would happen is that the screw would not hold the cylinder into the abutment anymore. So we need to find something to overcome this problem. And what we did was, and I'm not going too much into this because my colleague, Mr. Antonio Silva, will discuss it further, but we used these titanium sleeves. These titanium sleeves are used for allowing the prosthetic screw to make pressure not on the PEEK, but on the titanium sleeve. It's like an interface for an implant system. And after we developed this, we thought that we had all the conditions to move along and to go for the real study with a much more larger sample of patients. And we use our clinical approach that we were doing for more than 20 years, as I told you, but now with the PEEK. So I will illustrate a few cases to show you the materials we use, how we did it. And this was one of the first cases that I rehabilitated, a very nice patient, edentulous on the upper jaw, almost edentulous. She had 1 molar on the second quadrant and rehabilitated with removable prosthesis. And I think these patients are very good patients to treat because they are already with a severe condition. And when we replace the removable prosthesis for fixed prosthesis, we really create a gain in their lives. Their lives really improve. And so this is our starting point. The proposed treatment was a bimaxillary all-on-4, upper and lower, and then the final rehabilitation with the Malo clinic bridge. In this image, you can see the provisional immediate prosthesis. You see the sutures already still in place, and these provisionals are all acrylic. So we tend them to be as close to the final result that we want. If we need to change some things, we will probably need to redo this provisional. In order to have a very good final bridge, we need to have a very good provisional bridge before. And you can see the improvement, the happiness of this patient only with the provisional. So now, after 4 months, it was time to move to the final rehabilitation. And for the final rehabilitation, we use all the conventional clinical procedures. Digital is, at this point, not advanced enough to be used to make full cases with implants, in my opinion. So we are still using silicone for the impressions, and we obtain the master casts. As I told you, the provisionals are really important for us because all the design of the infrastructure will be made according to the references that the provisional will give us. So we, besides having the articulation of the two master models, we also try to have all the information from the provisionals. If the provisionals are not in such a condition that we can use them, then we should redo them before moving to the final rehabilitation. And we can use a lot of techniques to have references from these provisionals. We can use silicone matrix, we can use digital scanning now at this point, but either the way, our purpose is to design infrastructure that will be perfectly inside the thickness of what we want to be the final restoration with the right measures to have the appropriate resistance. And after, we can mill it. And this is how we obtained the infrastructures in PIC material, already with the titanium sleeves inside, as you can see. Then these bars, they are just covered with pink acrylic and stock teeth. So this is, at this point, if you don't see the cylinders, you cannot tell if it's a titanium or a PIC infrastructure beneath. And the final result after setting, after all the proofs and all the adjustments necessary, and a happy patient. So this is exactly the same technique that we were using, but instead of having a very rigid titanium infrastructure inside, we have a more resilient PIC infrastructure. Of course, in these bimaxillary cases, they are more prone to problems than the single jaw cases. We need to be very careful with the occlusal scheme. The proprioception of these patients are lower than patients that still have natural teeth. So it's very important to obtain a very good occlusal scheme and good canine guidance, incisal guidance. Otherwise, we will find for sure some complications. Another thing that it's very important with this is the angulation of the abutments, because with the titanium sleeve, we need more space for the acrylic and the veneering material. So before moving to the final bridge, besides having a good provisional functionally and aesthetically, we need to make sure that the prosthetic exits of the prosthetic screws are really on the right places. Otherwise, the structure can be compromised by that. And here you can see the panoramic X-ray of the final rehabilitation. What you see above the abutments are the titanium sleeves. They are not really in contact with the abutment. And then you can see the contour of the peak infrastructure. Okay, in these cases, we used acrylic teeth and pink acrylic resin. But we can use the versatility of PIC and use it with other veneering materials. In this case, also of a patient that I treated with a periodontal problem on the maxillary jaw. The lower also needed treatment, but for economic reasons, the patient was only interested in moving to the upper jaw and treated it first. So I started thinking, with only these lower teeth, I would like a material that could be easily repaired, because the probability of having some fractures of the acrylic would be high. So I decided to use composite instead of acrylic. So you can see here the same. After the surgery, you can see the sutures, the provisional bridge in place. And on your right side, you can see that the exits on the anterior implants are too close to the vestibular aspect of the incisors. And this is important because I cannot move to the final rehabilitation with the titanium sleeve over a PIC infrastructure with that type of exit. So here is the post-op panoramic X-ray. You see the titanium cylinders, and you can guess the acrylic. And then we move to the final rehabilitation. The clinical steps were the same impressions, the same articulation, crossing the provisional models with the opponents and with the master cast. And then we did a setup. This setup was tried, and when approved, we ordered the PIC infrastructure. Always we need to give references to our technicians. And here you can see the silicone guides that were made through the setup and will help, in this case, Mr. Antonio, to prepare the PIC structure to give the enough clearance for the composite veneering material. And on the right, you see that we are controlling the reduction of the framework, always with objective references. So after the framework is ready and all the procedures can be made for bonding the composite resin. Also, Antonio will go more into the preparation of the PIC infrastructure. But here you can see already with the composite layered on top of the PIC framework. Then it was time to move for the pink composite also, for the soft tissue. And here you can see at a stage in which it's not yet concluded, but almost. And then the final result. So this case also has a PIC infrastructure, but instead of used stock teeth and pink acrylic, we used composite, normal composite, and also pink composite for the soft tissue. And the case in the mouth, okay? Of course, with this, we can obtain and achieve a more individual aesthetics because we can characterize the composite in a different way that we can with stock acrylic teeth. And also, if something is break an incisal edge or something, any dentist can easily repair it. With stock teeth, we need lab to take some of the concerts that might be needed. So you can see the final result and a very happy patient also. Of course, when we take the X-ray, it's different from the other one, because in this one, you can see the composite radiopaque material around the peak infrastructure. So it's different from the panoramic X image that I showed you on the other case. And the last case that I will show with the third veneering option. In this case, I use ceramic individual crowns over the peak framework. It's what we call the Malo bridge ceramic. As you can see, this patient only had one maxillary teeth, a canine, that was used to hold the removable denture. The proposed treatment was to remove it and to do a conventional all-on-4 on the upper. But we would keep all the lower natural teeth. So when we have this kind of situation, what I would like was a material for use as a veneering that would match the same properties of enamel. I know that if I will use acrylic, I will have the natural teeth wearing out that acrylic. If I use composite, it will be better, but also the teeth are more wear resistant than the composite. So the ideal situation for me was a material that would match the wear of the natural enamel. And the Emax has a wear abrasion coefficient very close to the natural enamel. So that was the material I chose to use. And here is the same, the post-op panoramic X-ray prior to the beginning of the final rehabilitation. And here you can see the design of the framework. Of course, the design for this kind of rehabilitation is totally different from the use of composite or acrylic teeth. It's more difficult. We need to make sure that the preparations will hold the crowns and also will give enough room for the Emax that will be cemented on top of this. After production of the framework and the individual crowns, you can see Emax, and then we will cement adhesively to the peak framework. The conditioning of the Emax, the lithium disilicate, is completely straightforward, but we are still finding which one is the best way to condition the peak for the cementation of these restorations. So far, we haven't have any kind of problem with this technique so far. And here you can see the final grounds cemented and the framework in the mouth of the patient. Of course, this technique allows us for the best aesthetic outcome of all the three that I showed you. Of course, it's also the most expensive and the most time-consuming. Regarding the ease of repairness, it's very easy. if one of these crowns would break or chip or something, I could treat it even without removing the whole framework. I can just cut that crown, put a provisional, and order a new crown that will be cemented on the same place. So it's very easy to maintain over the years with this technique. And regarding the comfort and the aesthetic, of course, the ceramic is a very pleasant material with a lot of characteristics close that match closely the enamel. So it's, for me, my favorite rehabilitation technique, this one. And another situation regarding the X-ray image, of course. Here you can see the lithium disilicate crowns all over the titanium framework. So these were the 3 ways to rehabilitate patients. It's possible just to the 3 ways that we use to rehabilitate the patients. And these were some of the cases that were published on this article that we published recently with the 1-year results of follow-up. Today, I will show you the results that we have. We have not published these results that I will show you, but these results gather all the data from these 2 years of follow-up. The article only shows the 1-year follow-up. So we designed the study for using with 37 patients treated, and these patients, some were bimaxillary cases, and the number of prostheses that we delivered that are still in function was 49. And the follow-up at this time is ranging 2 years. What we wanted to measure, well, we defined our goals into primary objectives and secondary objectives. Of course, the most important for us was to check what would be the prosthetic survival. But then we want to measure another things like the implant survival, technical complications that could arise during the treatment, mechanical complications, biological complications, and a few more that I will not go into, but Dr. Miguel Nobre will cover that in his presentation, like the bleeding, patient satisfaction, etc. So here, in covering our primary measure, we have 98% of prosthetic survival. Why? Because one of the patients made a fissure on one of the peak infrastructures. I'm sorry, that patient is my uncle, and he is really a heavy bruxer, and I think this fissure that arose was a problem with the design of the framework. The framework was too thin around the titanium sleeve, and it had a fissure. So it had to be repeated. But 98%, a very good result for the prosthetic survival. When we cover the secondary measurements, regarding implant survival, we have 100%. None of the implants were lost. And for me, the biological results of this study are probably the most impressive for me. Now, regarding technical complications, problems that arise due to the strategy and the protocols that we use in the manufacturing of these prostheses. Then we had problems, but these problems were all on the first year of the study. and the problems were especially the veneer adhesion issues. We had 6 patients with 7 prostheses. One of the cases were bimaxillary that had this kind of problem. So to solve it, what we did was we changed the procedure. We changed the primer. Antonio will also cover that in detail in his presentation. We changed the preparation of the PIC infrastructure, giving more mechanical retentions to the material, to the veneering material, and also increasing the PIC thickness. Why? To avoid fissures around the PIC structure, and to have less flexibility also from the PIC. And I have to say that after we made these changes, during the second year, we didn't observe any kind of adhesions problems to the PIC infrastructure. Regarding biological complications, then we experienced very good results with bone losses that are really excellent. And also, I will not go too much into this because Dr. Miguel Nobre will also speak a lot about this characteristic of PIC, this biocompatibility, in his presentation. Sorry. Mechanical complications. Here we saw a few also. And in the first year, we had one patient, my uncle, with his 2 prostheses. One had a fissure and had to be repeated, and the other one, he broke the acrylic, and we had also to repair it. And this, as I told you, was solved by changing the design of the structure. So what we did was we increased the bulk around the cylinders, around the titanium sleeves, so we can achieve higher resistance for the PIC infrastructure. And the other problem that we saw was loosening or fracture of the prosthetic screws. And this happened before the final torquing of the prosthetic screws. So the screws that become unscrew, they were only with manual tightening. So we solve it by torquing it with the appropriate force and adjust the occlusion. And also, some of these patients, they were not using the night guards regularly. So we also tried to make them use it. On the second year, I will show you, we had a few other problems. We have one patient that had a fracture of an acrylic tooth. It was not the case in which the acrylic tooth debonds from the PIC. It was really a case in which there was a fracture of the acrylic tooth. So we had to repair it, adjust the occlusion, and also advise the patient to use the night guard, because most of these problems, they occur during the night. So the night guard is extremely important to protect our restorations on this period. And we also had one more patient that that showed us a unscrew prosthetic screw. So these were the problems that we encountered during our tests. And the conclusions that we took from it were that the survival, both regarding the implants and both regarding the prostheses, were really high. And I think that the fracture of the PIC infrastructure that we had, it was not really a problem of PIC material, was a problem of our design and the application that we give to that framework. We saw also what we can consider a low incidence of mechanical and especially biological complications, but of course 2 years for this type of treatment is a small period of time. We need to see this in 3, 5, and hopefully 10 and 15 years to see how will be the behavior of these frameworks. But what I can tell you from my clinical experience, what I see from the patients that I treat, is that they all feel very comfortable. The feeling of using this type of restorations, in my opinion, is better than when we have titanium. They are more comfortable, and probably that aspect has to do with the resilience of the PIC that patients, they don't feel with titanium. They feel that there's no kind of shock absorbance. It's too rigid. And with PIC, they really show a very good adaptation and a very good, they are really happy with the result, as you can see. And this, for me, it's the most important, is to really improve people's life. And I really hope that PIC is something that will help us to achieve these results. So this concludes my presentation. Thank you very much for your attention. Thank you.